Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. This episode features a discussion on PARP inhibition in the treatment of pancreatic cancer. It is part of a larger educational program entitled PARP Inhibition in the Treatment of Pancreatic Cancer, Current and Future Perspectives on Personalized Therapy. During this podcast, Dr. Agop Philip from the Karmanos Cancer Institute in Detroit, Michigan, and Dr. Elena Chiorean from the University of Washington School of Medicine and the Fred Hutchinson Cancer Research Center in Seattle, Washington, will discuss the importance of testing for biomarkers along with the current treatment landscape of pancreatic cancer. For more information on Dr. Philip and Dr. Chiorean, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
My name is Dr. Philip. I am a GI medical oncologist. I have a special focus on pancreatic cancer. I also do neuroendocrine tumors. I practice at the Karmanos Cancer Institute, which is affiliated with Wayne State University in Detroit. So I have my colleague here, Dr. Chiorean. Dr. Chiorean, do you want to introduce yourself to the audience?
Of course, Philip. I'm Agop Chiorean. I'm a GI medical oncologist at University of Washington and the Fred Hutchinson Cancer Center in Seattle, Washington. I treat patients with gastrointestinal malignancies. My research focus is pancreatic cancer, and I'm delighted to be here today.
Well, thank you. And I'm privileged to be with you today on this podcast. Gabby, let us understand what's happening in advanced pancreatic cancer or in pancreatic cancer in general. And the focus is on systemic treatments because we know that surgery has, it has its limits because most patients come to us with we don't have a surgically resectable disease. So what has been the advance, you would say, over the last 10 years in the systemic treatment of pancreatic cancer?
Definitely, Philip. So in a nutshell, I would say that we doubled the median survival from about 6 months to about a year with multi-agent chemotherapies, whether we use FOLFIRINOX or gemcitabine nab-paclitaxel. And I would say most recently in the arena had been the approval 2 years ago of a PARP inhibitor for patients with germline BRCA mutations. So I would say that this is a big advancement in the field.
And correct me if I'm wrong, but the PARP inhibitor, olaparib, which has been approved by the US FDA, this is probably the only targeted treatment available for this disease, for pancreatic adenocarcinoma?
So we have a few tiny, less than 1% subgroups of patients with MSI high tumors or NTRK fusions, which benefit from some umbrella therapies that are NTRK inhibitors and immune checkpoint inhibitors. Those are very small populations that have approvals in the refractory setting. But outside of those, indeed, the olaparib approval is unique in the first-line setting as a maintenance therapy.
I have several patients who I have treated recently, and I have, in fact, one patient who I just sent a prescription for olaparib. And one of the things which really I find it very interesting and very useful actually for the patient is that this was a younger patient, like she was 48, and she got the FOLFIRINOX, and she completed approximately 4 months of treatment, 8 cycles. And she was really getting now the side effects of the treatment. She was getting more tired, more fatigued, the myelosuppression and the platelets were having problems. And because she was BRCA2 mutated at germline, we are now switching her to olaparib. And she was very happy with that. What sort of side effects do you think she will expect? I mean, certainly better than getting the FOLFIRINOX and all the IV and the bag and all that. What sort of side effects do you think she will expect? Just give us just a brief thing. Do you think her quality of life will improve?
Yes, I think that the quality of life with single-agent PARP inhibitors is definitely much improved comparing with continuing chemotherapy. We do expect still to see some mild fatigue, potentially mild nausea, even diarrhea for some patients, as well as I would say neutropenia, myelosuppression is an expected side effect. But in comparison with FOLFIRINOX, clearly the side effects are much more tolerable.
So one of the key things in order for us to figure out which patients will be benefiting from a strategy of maintenance with olaparib, we talk about testing the patients. And I think this is a very important thing which we have to stress, because we were not used to testing for biomarkers in this disease. So that's something which is very important. So we have two types of testing. We have testing for somatic mutations, and we have testing for germline mutations. Can you elaborate on that?
Yes, absolutely. So in the NCCN guidelines, we have, again, national recommendations that all patients with no matter what the stage of pancreatic cancer should undergo germline, which means either a blood or a saliva sample to test for mutations that exist in every cell of the body, so to speak. So these tests, especially the color genomics from saliva or in vite, in blood, etc., are very, very easy to be done. The results do take approximately 3 to 4 weeks. And I would say it's best for patients to be tested when they first come to a cancer clinic. That way we have the results on time when, again, the time comes for the maintenance period. So the germline testing is standard. Now the tumor, the somatic mutation analysis, I think it's also very important. We have to remember that the olaparib approval comes only for patients with germline mutations, not for those with somatic, despite the fact that we know the somatic mutations benefit as much as the germline from PARP inhibitors. So it is, again, also standard for patients with advanced disease, metastatic or locally advanced, to undergo tumor genomic testing and discover those BRCA mutations as well.
So I think one of the important things which we learned over the last few years is that for a long time, obviously, we always were thinking of hereditary and hence BRCA1 or 2, linking it to hereditary cancers, and pancreatic cancer is one of them, because patients can have first-degree relatives with pancreatic cancer, but then our knowledge expanded into other cancers that can also happen in the family, not necessarily pancreatic cancer, that we should be aware of, like ovarian cancer, breast cancer, of course. In my opinion, one of the things that really is important for people to know is that half of the time the patient may carry a BRCA1 or 2 mutation without any first-degree family or secondary family history of any of these cancers, pancreatic, ovarian, or breast. And for that reason, the guidelines now say that any patient newly diagnosed with pancreatic cancer should be tested or considered for testing for germline mutations. This is really a very important aspect of the management of the patient. In my opinion, in my personal opinion, it should be part of our staging even process, that when you do, like when we do staging, we have a checklist of things we have to do, and the germline testing has to be a part of that, because it impacts the patient's treatment, and we'll come to that in a minute. But also the other aspect of it is that if the patient does indeed have a germline mutation, then that means that the family has also needs to be tested. So the two questions I have for you here, or we can discuss the two issues. One of them is when to test, and I think you touched on it. It has to be done at diagnosis, and I call it part of our staging process. And the second point to make is that how do you do it? Because since it's a genetic test, some people will say, I'll refer the patient to the genetic clinic. The problem is you refer the patient to the genetic clinic, but that can take a while. I know during COVID, people can do telehealth, but still people are waiting for genetic clinic. The other option is what I do is that I take the blood and send it the day the patient comes to me. And in fact, it doesn't take 3 to 4 weeks to the place I send to. Within a couple of weeks or 10 days, I get an answer regarding the germline. How do you do it? Do you send your patients to a genetic clinic, or do you just send the blood out to a vendor who can do germline mutation on the peripheral blood?
Yeah, so two ways, exactly like you said. So we do have genetic counselors in our multi-D pancreas clinics, and all of our new patients for pancreas cancer at the center come through these multidisciplinary clinics, whether they are metastatic or not. And therefore, we have the genetic counselors available on the site, on the spot, to engage with the patients. Oftentimes, though, for those advanced patients that maybe come from just a second opinion or else, I typically do this combined tumor, somatic, and liquid biopsy testing. Let's say with the Tempus platform is one of them. And we do pick up on these germline mutations in the blood, in the liquid biopsy. Of course, that's another way, very simple way that can be done without involving a genetic counselor.
So the question will be, number one, does the patient have a mutation? Number two, so what if they have a mutation? How will it impact what we do? Let's not discuss the hereditary aspect and screening for the other family members. Let's focus on treatment, because that's really what matters at that point in time to the patient. How do you think this will affect your decision in terms of giving the patient treatment? Now, we know we have two regimens. One is FOLFIRINOX, the other one is gemcitabine nab-paclitaxel. There might be other options for patients. How do you really think of the impact of germline testing or somatic testing? But germline is our focus because it's easier. You don't have to think of, well, did I get enough tissue sample to send for somatic? Germline is definite, it's there. Now, maybe some patients will have somatic mutation, not germline. And again, those patients are in a gray area anyway. But if we follow the strict guidelines, we need to do germline. How do you think it's going to impact the treatment?
So that's exactly why it's important to test initially, not to wait months and months. It's because the chemotherapy platform that we use, if we know a patient has a BRCA, an underlying BRCA mutation, that patient may be better served by a platinum-based chemotherapy platform. We have the FOLFIRINOX data. We have gemcitabine and cisplatin, which the group from Memorial Sloan Kettering had shown responses with platinum chemotherapy are in the 65 to 70% range. So that can actually make big difference for a patient if we know they have the BRCA mutation. So I think that you think about a specific, chemotherapy backbone with platinum based, if you know there is a BRCA mutation, as well as about the opportunity to have them have a chemotherapy break if they have a stable or response after 4 months, and put them on a platinum, on a PARP inhibitor maintenance.
So I think what you're saying is that it is an attractive strategy, and having treated pancreatic cancer for a long time, I'm sure you agree with me, is that those patients, we gave them chemotherapy, but many of those patients, you give them chemotherapy when they're responding and or disease stability, they're paying the price of also being debilitated by the treatments. So here you can switch off from conventional cytotoxic therapy to an oral pill. It's an oral pill. It has side effects. We're not really saying that it's a sugar pill, but at the same time, it's better tolerated. The logistics of going through that treatment are easier for the patient. But again, the key point is trying to do this testing as soon as possible when you see the patient, so that you can have a longitudinal plan for the patient, and the patient is aware of what the chances are. Now, here we're talking about patients who are responding or stable on the treatment, and if they have BRCA1 or 2 mutations, as you mentioned, it's like over 70% of the patients who will really end up in that sort of situation, which is a good thing for the patient. So it's a major change to how we were treating those patients.
No, absolutely. And I think that the question that comes in mind, and I think this is an individual patient discussion, is when to stop the chemotherapy, whether to stop the chemotherapy or to keep going if the patients, let's say, tolerate it well. And we do know that really the PARP inhibitors delay progression when they are offered in a maintenance setting. And we also know that among these patients, many actually can respond and be alive more than 3 years after starting treatment. So I think that many can have very, very long survivorship, and this is a very meaningful opportunity for them.
No, I agree. I mean, for a long time when I gave lectures, I said the median survival is stopping around 11 months in the best of scenarios. But with the availability of the PARP inhibitor, at this point in time, we have only olaparib indicated for this disease in this setting. We are exceeding the 12 months median survival for the first time. Now, granted, this is in a small population of the patients, but nevertheless, at least it's an opportunity. And we just have to build on it. I think more is to come, and hopefully we will see that in the coming years.
Yeah, absolutely, Philip. And what do you think you would see moving forward for patients with BRCA mutations?
Certainly, we have to expand the benefit of PARP inhibition. As you are aware, there's currently a study in the United States in patients who have early stage disease where they undergo resection and they received adjuvant chemotherapy, which happens to be FOLFIRINOX, the regimen of choice. Certainly, that study will allow more patients to benefit from PARP inhibition. There are studies looking at combining PARP inhibitors with other drugs like immunotherapy. So the field is really a rapidly evolving field, but we go back to the core issue here is that people have to be tested promptly and done in the right way. It shouldn't be left to someone with a family history, oh, they can have BRCA or BRCA not, because it doesn't work that way, because half of the patients don't have a family history. So the issue of testing and doing it promptly and doing it the right way is really very important. And I think this is happening. I think more and more people are being tested for the BRCA mutations, but certainly in a busy practice where providers are dealing with many other tumors, we need to really remind them that this is something which really is now part of the standard of care.
No, absolutely. And I think for patients that have a long survivorship, you know, what comes into mind is also there is a higher risk of prostate cancer. We actually see a lot of colorectal cancer patients with BRCA mutations. We never know how much of that is a driver or not, but I feel that even beyond breast and ovarian, you know, patients and their families may be affected. And maybe we can make some improvements in those fields as well. I'm very thankful for the audience listening to both of us today, and I hope that you learned a little bit from us. Looking forward to talking more in the future with some new updates. Philip?
Well, again, I would like to thank you, Gabby, for this very interesting conversation we had. And also I'd like to thank everyone who is listening to this podcast, because this is an area of management of pancreatic cancer that we've been waiting for it, because we really want to get more into target therapies and all that. So I do appreciate the fact that people are interested in hearing this, and if they have any comments, we'd be happy to really have them also. Thank you very much.
Thank you very much, Dr. Philip and Dr. Chiorean, for that excellent discussion, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, PARP inhibition in the treatment of pancreatic cancer, current and future perspectives on personalized therapy, from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.